This audio presentation was pre-recorded and edited for brevity and clarity.
Hello and welcome. My name is Dr. Diane Bevenkamp, Vice President of Scientific Affairs at BrightFocus Foundation. I'm very pleased to be your host for today's Macular Chat called Geographic Atrophy, Your Questions Answered. This chat is brought to you today by BrightFocus Foundation. Macular Degeneration Research is one of our programs at BrightFocus. We fund exceptional scientific research worldwide to defeat Alzheimer's disease, macular degeneration, and glaucoma. And we provide expert information on these heartbreaking diseases. You can find much more information on our website at www.brightfocus.org. That's brightfocus.org. I am pleased to introduce today's guest speaker. Philip Niles, MD, is a vitreoretinal surgeon at Buffalo Niagara Retina OCLI Vision, with special interest in age-related macular degeneration, diabetic retinopathy, vascular occlusions, retinal detachments, and macular holes. Dr. Niles is the author of numerous publications in ophthalmologic scientific journals and has presented his research at national meetings such as the Association for Research in Vision and Ophthalmology and American Society of Retina Specialists Annual Conference. Dr. Niles, thank you for joining us today.
Hey, it's a pleasure to be here. Thanks for having me.
And thank you so much. I know that you're in the middle of a clinic right now, but we know that we're getting, the best information fresh off the presses from you. So maybe I'll just start with, the first question is, or two questions. What is geographic atrophy, and how does this relate to the terms that many of us are familiar with, dry AMD and wet AMD?
Hey, those are great questions. Before starting, thanks so much for having me here. Super honored to be a part of this. I think that it's great the work that you guys are doing for patients and really answering patients' questions. A lot of the patients I see come in, with more so a sense of fear and concern. I really think that the more somebody learns about the conditions they have, the better off they are. So I think you guys are doing great work. In regards to your questions, what is geographic atrophy, and how does this relate to conditions like macular degeneration? I think it's important to point out that these are very common conditions. Macular degeneration, especially age-related macular degeneration, is really the most common cause of vision loss in the U.S. and is the most common reason that a patient walks into my door. What geographic atrophy is it's a condition that's on that spectrum of age-related macular degeneration. So what we used to call, advanced macular degeneration, I'd say is oftentimes considered geographic atrophy.
Oh, great. And
historically, that's more of the dry form is the geographic atrophy, versus the wet form is more about bleeding in the retina.
Great. And so it's the wet form that is, and there's advanced wet and there's advanced dry. So the advanced dry is geographic atrophy, and the advanced wet are the ones that people can get needles for, the anti-VEGF, right? But it's a different kind of macular degeneration, if that makes sense, right?
Yeah, well, great question. So I guess the way to think about it, and previously patients thought about it, was that if I have the wet one, I get the injections, and if I have the dry one, there's nothing they can do. And that sort of changed over time. Starting last year in 2023, we had 2 different medications get approved for geographic atrophy or dry macular degeneration. And while they don't, per se, get the resolution of a disease that we can get with wet macular degeneration, they can oftentimes slow down its progression, which it can be very helpful in some patients. So if I were to describe the difference between wet and dry, what I would say is if you imagine the macula or your central vision, the very focal point in the back of the eye, there's this line that separates the retina from the blood vessels. And that line degenerates in people as we go through life. And if it degenerates, somewhat, then the vision can degrade somewhat. If it degenerates enough, then the blood vessels from the back of the eye can leak into the retina. And once the blood vessel leaks, that's called wet macular degeneration. If there aren't any blood vessels leaking, then we call it dry macular degeneration. And just because somebody has wet or somebody has dry doesn't really well describe their vision. Somebody can have wet macular degeneration where that leaking blood vessel was caught very early, and they can maintain excellent vision. And somebody could have dry macular degeneration that never bleeds, and they can have significant vision loss. And so the difference between wet and dry is just the presence or absence of a leaking blood vessel. And now the difference between wet and dry is the difference of what treatment options we can choose from.
Yeah, I think that's been the most exciting thing that's happened. I mean, before it was, you know, the arid, you know, if you had intermediate dry, you could take those vitamins and maybe it'll help to slow progression to the late stage dry AMD. But what happens to vision as geographic atrophy progresses? Can you just briefly describe what happens? Or GA, I'll call it GA, geographic atrophy. GA is another word for it.
Yeah, sure. So when you get GA, or geographic atrophy, it's patches of your central vision that kind of go missing. And if it happens in the very center, that obviously can be quite debilitating to patients and make things like reading or watching TV or driving very challenging. Any task that involve your central vision. Sometimes you get geographic atrophy not directly in the center. It can be a little bit off to the side, and that's less symptomatic for people. But it's still important to note because you sort of watch the progression of that. And you know that if somebody has a progressing GA over time, that if it's progressing more quickly, then it's geographic atrophy that might be, more responsive to treatment. Versus if somebody has, central geographic atrophy, their central vision might already be very compromised. So what happens, and to answer your question, so what happens as geographic atrophy progresses? Well, if it progresses in the very center of the vision, then you get central vision decreases. If it happens off to the side, then oftentimes patients might not even notice that.
So it's almost like, people, it doesn't affect the same part of the retina in every person. So everybody, it could start in a different spot, and how your vision is affected just is the random chance of what you have.
It's really all about location. So if we think about the macula in general, it's actually a very small area. We're talking about 4 or 5 millimeters vertically and horizontally. That's super important to people. And where the geographic atrophy happens within those 4 to 5 millimeter squares, that's really what affects the person's quality of their vision, which has significant impacts on quality of life.
That's great info. So, so Dr. Niles, there are, as you mentioned, currently 2 FDA-approved treatments available for geographic atrophy that are called these funny names. Most drugs have funny names, so Syfovre and Izervay. Can you tell us about each and how they work?
Yeah, absolutely. So Izervay and Syfovre are 2 different medications that attack the same complex or the same pathway in the eye. There's this thing called complement, and that is sort of one way or one molecular pathway through which geographic atrophy progresses. And both drugs try to stop that pathway from progressing. Each drug kind of attacks a different part of the pathway. With Izervay attacks what's called C5, and Syfovre attacks what's called C3, or tries to prevent it. But they both function kind of similar routes from a big picture standpoint. Some of the major differences between the 2 drugs, I'd say, are actually the FDA's approval and insurance coverage for them. Izervay was able to get coverage for just 1 year of use. And that's somewhat of a limitation because with geographic atrophy, this is a chronic progressive condition that doesn't go away after a year. And so having 1 year of use for a condition that's not going away after a year has really limited, I should say, Izervay's usage. Syfovre, on the other hand, has had, I would say, better coverage for patients. And so more physicians have been leaning towards Syfovre. Syfovre you can use for as long as you'd like, and it can be dosed every month or every other month.
And can you switch back and forth between the 2? Like, I guess that's just like a decision between the healthcare professional and the patient, right? Especially if maybe someone doesn't respond to one or the other?
Yeah, that's a great question. It's tough because when we think about geographic atrophy, it's typically a very slow-moving condition. And what our data from the studies, and for Syfovre in particular, have showed that the longer a patient is on Syfovre, the better the difference is compared to if the patient hadn't been on Syfovre. And so in some, respects, there's this potential like lock-in effect or benefits with the longer that you're on it, which was very surprising. That's kind of atypical. Usually the medicine, loses its effect over time. But with Syfovre, we've kind of seen this continual improvement in terms of the rate of progression of someone's geographic atrophy the longer they're on Syfovre. With Izervay,
So
we haven't quite had the data to support that yet. Not that it's not true, and I imagine it would be true, but it just hasn't been shown. With the coverage only lasting a year, it's sort of limited in being able to apply that to your patient practice.
Oh, great. And yeah, and of course, as you said, these were just approved last year, so we'll be looking for more. Well, I guess one of the questions I was going to say, like, these treatments were both approved in 2023, and so, you know, as you said, you know, they're going to be continually collecting data. So, new data come out from continued studies on these drugs?
Yeah, great question. Syfovre just released some more data. They did what's called the GALE extension study, where they're hoping to test the effect of Syfovre in patients up to 5 years' time. And more data is being released as that study goes on. And so while we still don't have the final results because it takes 5 years, it's looking more and more optimistic. And I think what you were getting at is really important, and that this is really sort of like the first or second inning of treatments for geographic atrophy. You know, if you had come to my office in January of 23, we wouldn't really have had any treatment for geographic atrophy or for dry macular degeneration. And so this is our first iteration, and we're hopeful to have better and longer lasting drugs in the future. I think what's been so great is just how much research there is in this area and how quickly things have been progressing from a pharmaceutical side. It's been nice to have options to offer patients for diseases that we previously didn't have great options for. Just like you were saying, it used to be, you know, take the vitamins, and that was really all we could offer. But now, hopefully, we'll get better and better medicines in the future.
All right. I just thought that was a great analogy you used about, you know, the first inning. So you're talking about baseball versus, say, I like watching, you know, hockey. That's a fast-moving sport. So we have to think of this as, like, you know, lots of innings, you know, in a baseball game. So just we'll sit back and see what happens. So one of the questions that I have is, you said that so Syfovre and Izervay work on this path. So my understanding, I think this is like it's like inflammation, kind of like, you know, if you get allergies or something. So well, not exactly in allergies, but that's, so maybe if you get a bacterial infection, I think the C3 and C5 proteins kind of protect you against that, right? And is this just a matter of in geographic atrophy, the C3 and C5 proteins are like overactive or something, and so it's kind of like allergies where you want to try and take a allergy pill to dampen down the response or something? I know it's not a direct analogy, but is there a better way to explain what this pathway is?
Yeah, I think that's a great, you know, sort of way of describing it. But basically, it's just like we were talking about, that line that separates the retina from the blood vessels. That's responsible for sort of recycling these molecules that our retina, in the certain layer of the retina, the retinal pigment epithelium, sort of depend on to work. And when that layer doesn't work, these cells, you know, can die off. And so what this is really slowing down that pathway of the cells dying off. That's how I would think about it. But I think going back to what you were describing before about like baseball versus hockey, you know, when we talk about stuff like that, it sounds like something that's sort of like has this kind of defined path and defined timeline. But really, geographic atrophy is more like a disease that moves at somewhat of a glacial pace. And it's something that we're tracking, you know, once every 6 months or so in most patients who aren't receiving treatment for it. And so I think the best way to really describe this is when you go to your doctor and see your pictures over time. You know, when we check patients' pictures and I'm looking at their history, I'm looking at pictures from years ago in comparison to today when they're available. And I think that's the most important thing, that when we look at the pace of the research and the new medicines coming out, that pace is accelerating. And geographic atrophy, you know, we're just trying to stay in the game until we have better and better treatments for it.
And so, no, that's good to know. I mean, yeah, there's so many other drugs that are down the pipeline too. But just like, what is the goal of the treatment? So, what can people expect if they do get the treatment? Will it restore lost vision, or is it more like preserving what you have already?
That's probably the question I'm asked most frequently by patients who are considering this. And I wish we had something that restored vision for geographic atrophy. But it's important to note that we don't. I wish we had a way of bringing patients their vision back. But what these drugs actually do is they slow down the progression, or really the rate of the geographic atrophy forming over time. So when we monitor someone's geographic atrophy and how much area has atrophied, we kind of put a certain speed at which that's happening. And what these drugs do is they slow down that speed.
Got it. So basically, this is a really good plug for people to get their eyes checked every year, so you can get diagnosed early, because it's like, time lost is vision lost, right?
I think what's super important is having a good baseline. So for instance, if I see someone who has pictures from 5 years ago and they look the same as the pictures from today, they're not a great candidate for these treatments, because their disease is already progressing so slowly that slowing it down 25, 30, even 40% isn't all that helpful. If someone's only driving 10 miles an hour and you slow them down to 8 miles an hour, that's not super critical. But if someone's going like 60 miles an hour and you slow that patient down to 45, that could be meaningful to somebody over the long term. And so I think that's what's super important, is to just sort of be able to establish this history and this trajectory over time.
So that's actually really critical, and it kind of leads into the next question I had was, what do individuals and their healthcare providers need to consider before starting treatment? So I think you already answered kind of part of it, which is there's a lot of like wait and see. That's one of the options for treatment, like wait and see. If the rate is too slow, there's some kind of slope or rate after which maybe the healthcare provider can decide to start treatment.
Yeah, I think the biggest consideration for patients is how concerned they are about this and how much they think it will help them. I see a lot of patients who, if their geographic atrophy is progressing, let's call it at 30 miles an hour, just for an arbitrary number, and I tell them, hey, I have a treatment that can get you down to 22 miles an hour. I have some patients that would jump for that, and I have some patients that wouldn't really jump for that. But I think the important thing is having the conversation with the doctor about it and getting those pictures so you could see how things are going. Keep in mind all the different types of patients we see. I have a lot of patients who only have one good eye and would do anything to keep their vision in their good eye. I have patients who have a family history of macular degeneration. I feel like those patients really know what they might be up against, and those patients might be highly motivated. And I have other patients who, they're in their late 90s. They say, hey, I hate going to the doctor. If I really don't need this, unless it's really going to restore my sight, then I don't want to do it. We say, okay, don't do it. So I think what I'm really taking away from geographic atrophy treatments is that's a bit more individualized and much more, I would say, discussion-centric, versus you were talking earlier about treatments for wet macular degeneration. That somebody has to do, or they're going to lose vision quite quickly if they have a bleed in their retina. But with geographic atrophy, it's a bit more individualized and much less rushed.
That's really good advice.
This is a slow-moving chronic condition, and we just want to slow it down in accordance with patients' wishes on what treatment burden they'd like to have. But it's nice to actually have something that we can offer now versus before we didn't. And I do think that our offerings are, like I said, they're sort of the first iteration of offerings, and we're just trying to keep people in the game until better things come along. But I actually think that Syfovre in particular is helpful and very good at slowing that rate, which can be very impactful to people.
Great. So for listeners who are around the country, are both treatments widely offered by retina specialists around the country? And you need, this is something you have to consider in the U.S. Do you need pre-approval from insurance required or Medicare? Do you know anything about it, or is it just, individual?
That's a great question. I would say that treatments are widely offered by retina specialists around the country. I was at the American Society of Retina Specialists meeting. Everyone has heard of these drugs, and I would say almost every retina specialist, if they believe in them, are offering them. I wouldn't say that, I don't think that they're too new or something like that. They've had widespread adoption. I would say that in terms of pre-approval from insurance, everybody has a different insurance plan and sort of how to comment for an individual patient. But generally speaking, retina practices are usually very facile at navigating that insurance situation. So with a lot of the medications that we use and a lot of what we do, we require working with insurance companies. And so I imagine that, at least in our practice, I imagine most practices would be able to handle that quite easily. I wouldn't let that be a limitation for whether or not you're considering getting an evaluation.
Exactly. The most important thing is to understand, as much as you can before making a decision for treatment and getting the right diagnosis. Yeah. So I know another question I have is
Pardon me for 1 second.
Oh, yeah. Okay, great. And for everybody on the call, as I said, our Dr. Niles is at the clinic right now and it's active, and he had told us he might have to step out for a few seconds before he comes back. But this could be a good chance for everybody to go *3.
I'm sorry about that. My apologies.
Have any questions? Okay, great. I just told everyone that they could go *3 if they had any questions to go back. So, yeah, and so if my retina specialist is on the fence about starting treatment for geographic atrophy, and I know you're saying it's slow moving, glacially moving, should I seek a second opinion? I think that's one thing I think that came in from someone. Should I seek a second opinion, or how does it work at eye clinics?
Yeah, that's a great question, and I'm always very encouraging of second opinions in my practice. But I have to say, I think that the major dilemma with whether or not to start treatment is typically with the patient themselves, and to say, hey, do I want to do this or not? And that's really a personal decision. If we had like a miracle drug that got rid of the geographic atrophy, everybody would just do it. And if we had something that didn't really work, doctors wouldn't do it. But what we have is something that works, somewhat. And whether or not it's worth it for that is a patient's individual decision. And I think that's really where the dilemmas are. And so a lot of times it's more about, having a doctor that will have that conversation with you and answer your questions about it. So do you need to seek a second opinion? I think that's a personal decision a little bit, but I think a lot of this is more individualized, and it's not so complex where there's going to be different options. It's just more so like, what do you feel comfortable with?
Yeah, and I think that a lot of people may come from a generation or a culture where you might be more deferential to a doctor's opinion, but I think we might encourage people to trust in your own gut based on what you want to do. So I think that before we get into more listener-submitted questions, I have one last question, kind of looking a little bit towards the future, is I guess we're getting greedy now that we have 2 treatments for geographic atrophy. Are there any other treatment options that you know of, maybe from going to, the ARVO conference or other conferences currently being studied that may come to the market soon that you want to share with us?
Yeah, great question. There are a lot of treatments that are being researched right now in comparison to, other conditions or even other time points. Historically in retina, if you came in like 2005 or so, we had very limited options for you. And then we got some new drugs called every, few years. And now I feel like there's new drugs coming out much more frequently than there used to be. There's a couple of drugs in trial right now, none that are available currently. But I think what's really changing is that we're sort of learning from our experience, and that helps us design our trials a little bit better. So like, for instance, for Syfovre, we find that it's most effective in patients who have their geographic atrophy not quite in the center yet. Patients who were worried about it becoming part of their foveal involving or center involving vision soon. And so now when a company is designing a trial to hopefully get FDA approval, a lot of them are specifying that they're looking for patients who fit that criteria, patients who haven't yet lost their central vision, but are in danger of losing it soon. When previously the patients I'd say we were focusing on most are patients who were who had lost their central vision or were losing it. And so I think that in addition to having new molecules and new treatment options in the short-term future, I think what we're going to have is like better data as well, and we're going to have better clinical experience because of the drugs that are out now. So on one hand, yes, I think we're going to have better treatments called in 2 to 5 years. I also think we're going to get better at treating patients the more experience we get. And that said, I think we're at a good starting point now with the treatments that we do have and the experience that we do have. So I know it's a really great field. We wish we had like that holy grail of being able to reverse the geographic atrophy. We don't, but at least we have something that can slow it down.
Yeah, and then I was just going to say, I mean, it's not that the next ones might be better, but it just might attack different, as you were saying, pathways or disease-causing biochemistry of the disease, and so that might be the more drugs that are coming down the pipeline, right? That we can kind of add to this arsenal or toolbox for a clinician and an affected individual to just sit down and say, got it, need it, want it, and almost like, you know, where with cancer treatment, you can have some kind of personalized medicine. So we might be, you know, using Syfovre or Izervay for like, dampening down the inflammation, and then another drug might be, you know, trying to do something else, and then that would be really cool if we could get to a point where we can have like some kind of combo therapy.
Yeah, definitely. You know, I was working with an interesting company called Character Biosciences, where they took a genetic sample of thousands of patients and compared it to their images over years and said, hey, which like genes correlate to what types of changes? And can we design a drug to target that specific gene? And so I think things are going to get better in that regard. The other way that I think things are going to get better is that right now we're treating patients with, you know, disease that's been progressing for years and years and years, and now all of a sudden we're going to start treatment. When really we know from almost every other medical condition that the earlier you intervene, the better the outcome typically is. And so I'm curious if like over time we learn that patients should be on treatments earlier in their disease state. I see that most with my patients who have a family history of macular degeneration, and they come in asking, hey, how can I end up, you know, to not lose my vision like my dad did, or like my dad and my two uncles did. And I'm thinking, those patients sort of know what's coming. Why are we waiting for their disease to be so progressed to treat them? And of course, I'm not treating them with things that, you know, with anything yet, because we don't have anything to start treating disease that's in its earlier stages for macular degeneration. But it does seem a little counterintuitive that I'm like waiting for them to have geographic atrophy before we're treating something. But I think what's happened is that now that we know that we can come up with a treatment for the worst forms of the condition, we'll probably start designing treatments for the least worst forms of the conditions next. It's hardest to treat, you know, the later forms, and if you can do that, then you know you could probably do earlier forms too. And so I'm really hopeful that patients who have family histories of macular degeneration aren't necessarily resigned to their parents' fate. I think the drugs that we have now are helping to avoid that, but I think just as we learn to use these drugs more and more, we're going to avoid those outcomes even more so in the future. So I don't know, I'm very optimistic about the future with macular degeneration. I'm actually kind of optimistic about the present too. And I just hope we keep getting better options for patients and learn how to use them best.
Absolutely, and we'll keep looking out for those, the reports or the continual study of Syfovre and Izervay, and who knows what else. You know, once a drug goes on the market, there might be other benefits that you didn't notice in the clinical trial because it was too short. So I have a bunch of listener submitted questions here. One of the things it says, my retinal specialist said that GA can affect wet AMD as well. I have advanced wet AMD in both eyes, and what are the chances that I could get GA?
You know, that's a great question. A lot of times what that question is kind of driving at is we see patients who have geographic atrophy. I shouldn't say a lot of times, but in the clinical trial, there are patients who had geographic atrophy, and with treatments, they were more likely to also form wet macular degeneration alongside of it. And that rate, you know, if people weren't on getting a drug for their geographic atrophy, they were getting wet macular degeneration about, call it 2% of the time. And with these drugs, they were getting it up to 7% of the time. But basically, for somebody who has wet macular degeneration, I think it's important to control that first. Once the wet macular degeneration is under control, which we have several different types of medications to control it with, once it's under control, then one can consider doing it, treatments for geographic atrophy. But there are kind of two different issues along that same spectrum of disease, just sort of like that line that separates the retina from the blood vessels we were talking about before. If that line degenerates a lot, you lose some central vision from geographic atrophy. If that line degenerates enough and then has a bleed, then you have wet macular degeneration. But it's all kind of part of the same condition of macular degeneration.
Yeah, great. And here's another one I hadn't thought of that seems interesting. Can GA or geographic atrophy be linked or lead to thyroid eye disease?
There's definitely some risk factor that's tied to those in terms of it's been shown in studies that there's a connection there. I wouldn't say that GA can lead to thyroid eye disease, but that having thyroid eye disease is a risk factor amongst patients with geographic atrophy. But I have to say, I'm a little bit suspect of that linkage. You know, the issue is that when we do trials or study patients with geographic atrophy, we look for every other possible condition the patients in that trial have. And so we might be looking for, 50 different conditions. And if we look at 95% confidence interval ranges, well, then there's going to be like 1 in 20 conditions that pop up by random chance, even if there isn't really a signal there. And so I'm a little bit suspect of being concerned about linkages that are a little bit weak or that aren't well established. I have to say there are other things that there are strong linkages and risk factors. Like we talked about, family history is a strong risk factor for macular degeneration. Smoking is a strong risk factor. But other conditions, a little bit less so.
Yeah. Even age too, right? Age is like the #1 risk factor, the older.
Absolutely. The name of the condition is age-related macular degeneration.
But yeah, no, I think that whole thing that we were saying with the, it's correlation versus causation, or does GA lead to, or it's just associated with. So in this case, it might just be associated with and not leading to it or anything. It just happens to be held with people who are in the clinical trial. But anyways, here, let me see. I think you answered this, but is there like a more, is there a really succinct way you can tell someone what's the difference between age-related macular degeneration and geographic atrophy? If you were to sit down and...
Great question. If I were to sit down and show it to somebody, I would take a picture of their retina and I would look at the picture with the patient, and we can show if there's a patch of that retina that's missing, in which case that'd be called geographic atrophy, or if there wasn't a patch of retina missing and there was just some, flecks and some signs called drusen of macular degeneration. So what I would say is that geographic atrophy is an advanced form of dry macular degeneration. And just because you have dry macular degeneration doesn't mean that you'll necessarily form geographic atrophy or any blind spots in your vision. But I think it's really important to check in with an eye care provider, or a retina specialist, who can show you your pictures and explain the difference there and which you have.
Yeah, I mean, a lot of times you'll go and have pictures taken of your eye and they don't show them to you. So that, I like how you're helping to enable people to take an active role in your own healthcare and to ask questions and ask to see them. People might not know they have a right to see them.
Yeah, and I think it's great for the patient to help so that everybody can understand what's actually happening and what's going on, to see if there are any changes over time. Because a lot of people have macular degeneration that doesn't really change or progress, and other people have macular degeneration that can be progressing quickly. And so I think it's important for the patient to sort of be aware where they stand.
I'm going to forever have that image in my mind of a glacier slowly moving across the continent.
But that really is geographic atrophy for some people. For some people, we watch them and they barely change over time, and we tend to leave those patients alone. And then we have other patients where it is changing actually somewhat quickly, and we now have options to treat patients like that with. And so I think it's important for each patient to sort of have a good understanding, and that starts with an evaluation with a retina specialist or an eye care provider who can take a picture and show them what's going on.
And as they say, yeah, if it ain't broke, don't fix it. So if it's just like, if the glacier is just sitting there, don't go in there and do anything yet.
Yeah.
Okay, so I think this is the last question before maybe we wrap up, and then maybe I'll ask you if you have any final thoughts for people. Is one person asked, there are sites across the U.S. where, well, we know across the world, but across the U.S. where that there's GA research that's aggressively being done. This person is saying, my GA is advancing, so should I go to one of those sites for a consultation? Because I want to make sure I'm seeing the best care.
Yeah, that's a very reasonable and fair question. I would say that that's a question that should probably be asked to the patient's retina specialist. I would start with, your retina specialist, and there's a lot of clinical trial sites across the country. I think before that would have been an even stronger yes, because we didn't used to have any treatments. Now that we have 2 treatments available for geographic atrophy, I think that the need to be in a clinical trial is somewhat lower than it was before, at least from a patient's, standpoint in terms of feeling comfortable with what's happening. But in terms of a clinical trial, I think it would be best to start with a retina specialist and then go from there to see if that would be helpful for you. Because a lot of patients, if they're not progressing, then that's something that doesn't even need treatment, let alone a clinical trial. And so at the very least, I would work in conjunction with your retina specialist to say, hey, I'm considering a clinical trial. What do you think of that? What do you think we should do? Where can you direct me if you don't offer it, presently or locally? Because I think it's just important that if you're looking for treatments that are a bit more experimental, to be doing it in conjunction with a physician who's experienced with those.
Wow, that is really, really, really key, important advice to protect yourself, because there are people who try to take advantage out there, and I think that definitely talk with your retinal specialist. And we actually have on our website, we have worked with Antidote to have kind of a specialized search of clinicaltrials.gov, where you can go on our website and see what, you can put in geographic atrophy clinical trials. What are there out there? And it doesn't necessarily mean that, all of those are legitimate, but you can at least check and see whether that one you're thinking of is in there. So, and then you can print it out and bring it to your retinal specialist and ask questions. All right. So, Dr. Niles, thank you for sharing so much information with us today about geographic atrophy. To our listeners, I sincerely hope that you found today's chat helpful. People who know me know that I could sit here and talk for hours and hours and hours, but yeah, I think we talked about a lot today, didn't we?
Thanks so much for having me.
Yeah, we are taking a quick 1-month break for the summer, but 1 month. And our next Macular Chat will be on Wednesday, July 31st, so the very end of July. We hope you can join us. And Dr. Niles, before we conclude, I mean, our discussion today was amazing, and I'm so happy that we could tap into your brain. But are there any final remarks that you'd like to share with the audience?
No, nothing in particular. I think if I were to have one point of emphasis, I think the important thing is to check in with a local eye care provider, especially if it's a retina specialist, if you're concerned about having significant macular degeneration. I think it's never been more important to get a baseline evaluation now that we have treatment options that we've never had before. So that would be my only point of encouragement, is to get an evaluation with a doctor if you're worried. Thanks for having me today.
Yeah, or you have the family history, as you were talking about. It's good to have the baseline, right?
Definitely.
All right. Well, thank you again to you, Dr. Niles, our guest speaker, and to our listeners for joining us today. This concludes today's Macular Chat.
The information provided in this recording is a public service of BrightFocus Foundation and is not intended to constitute medical advice. Please consult your physician for personalized medical, dietary, and/or exercise advice. Any medications or supplements should only be taken under medical supervision. BrightFocus Foundation does not endorse any medical products or therapies.